From the JAMA Network, this is JAMA's Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today, we will be discussing the review article, Whole Blood Transfusion from Empiricism to Evidence, a narrative review. You can find a link to it in this episode's description. We are here with lead author, Dr. Crisanto Torres from Boston Medical Center. Thank you for joining us today.
Thanks so much.
Well, we are definitely talking about a topic today that is near and dear to my heart as a trauma surgeon. And yes, we're talking about whole blood. And well, what's old really is new again when we're talking about blood transfusions. And I'd love to start, if we could, with a little history recap. Could you walk us through this cycle of whole blood?
So yeah, exactly. This is a centuries-old practice. It's not anything new. So whole blood really was first utilized in the early 20th century, actually during World War I, when Captain Robertson experimented with human-to-human transfusions and was actually able to learn how to store blood. And at that time, it was being whole blood. And so they actually utilized the British and American forces whole blood as the preferred modality to transfusions as opposed to other colloids or crystalloid at that time. And so this continued to evolve during the Second World War, in which the British forces and the American forces were able to now have a more kind of organized and structured blood bank. This continued throughout the additional conflicts at that time, the Korean War and Vietnam War. And so actually during these times of conflict, almost 1 million patients or 1 million soldiers were actually transfused with whole blood during this time.
Wow. And it's crazy that we went away from that, but we did. Can you talk to us a little bit about what more recent transfusion practices are like?
Yeah, so actually we did gravitate away from whole blood a little bit after Vietnam War. And at that time, the issue was more so a logistical issue with blood banking and supply chain logistics. And so we were able to learn how to actually separate and fractionate whole blood into respected component parts, red blood cells, plasma, and platelets. And what that did, you can actually fractionate one donor's whole blood and supply multiple units of blood that can provide blood transfusions to multiple recipients. Additionally, those component therapies had longer shelf lives compared to whole blood. And so this actually increased the efficiency and inventory of blood product for both military and eventually civilian populations. But there was no clinical evidence behind that. It was more so from a blood banking and supply chain perspective.
And I think that's such a great point to highlight. And I also want to highlight this military to civilian transfer of knowledge. And to quote from your article, hemorrhage remains the leading preventable cause of trauma death, and many fatalities occur before definitive hemorrhage control. And really, this resurgence of interest in whole blood stems from our military colleagues, such as Dr. Jen Gurney, who showed improved survival and reduced early mortality. And really, Dr. Jenkins, one of your co-authors, was the one who engineered being able and taking this practice from the battlefield to the civilian setting here in the United States. And given this information we have from a military, some people may wonder, why don't we just use whole blood all the time? Can you walk us through some of the challenges and obstacles of using whole blood here in the United States in the civilian setting?
Yeah, exactly. And you're correct. Dr. Jennifer Gurney and Dr. John Jenkins and Dr. John Holcomb, Phil Spinella, these are the pioneers that really saw through the military's experience and again, through those conflicts, those recent conflicts in Iraq and Afghanistan, the benefits and what they were using was fresh whole blood, which is a little bit different in terms of the cold stored, low titer group of whole blood that we actually utilize in civilian practice, but similar into concepts. But there has been, and there continues to be these barriers and these obstacles that we do experience in the civilian population. One is the evidence, right? I think that's probably the main barrier at the moment. The majority of evidence that we have with whole blood and really comparing it to component therapy is really largely based off observational studies, right? Or military's experience. And so that's where I think that the challenge is mainly at the moment. But there are other logistical, possibly cost-effective obstacles that we also encounter in this particular space.
Yeah, there's a lot of logistics, as you referred to earlier, with storing that blood and getting it to where it needs to be, especially in the United States, where we have a large area in the United States that is rural and isn't close to a level 1 trauma center, for instance. And so, as you've mentioned, your article is incredibly comprehensive and utilizes evidence from military, civilian, and pre hospital settings. Can you highlight for us what the current evidence is for whole blood in civilian and pre hospital settings?
Yeah, absolutely. So, as I mentioned, the majority of the evidence comes from observational studies, retrospective, large nationwide cohort studies, multi centered prospective analyses from Dr. Brill and Dr. Hazelton is another one, who actually saw that there was an associated survival benefit and reduction in transfusion requirements among patients with trauma and severe bleeding. But that hasn't really translated yet in terms of the pre hospital space. And I say that because the more recent SWIFT trial and the more recent Tower trials, right? These pre-hospital randomized controlled trials looking at whole blood versus component therapy. And I think that makes the evidence a little bit more difficult to interpret. And specifically when mentioning these two trials, the nuance and the neutral results are really based on the comparator, the patient selection and population. And really what I want to stress is actually the system that delivered whole blood as an intervention.
Absolutely. Are you aware of any particular safety concerns with using whole blood? I mean, we know that there are always safety concerns when we're talking about blood transfusion, but is there anything particular to whole blood that you think our listeners should be aware of?
Yeah, so there's been, several years ago, and even now, when I speak with individuals who have never heard of whole blood transfusions, and when I say that, actual physicians, doctors, even some surgeons, the question is, well, is this safe? What is the risk of serious transfusion-related reactions and hemolysis? And it's actually the same as component therapy. This is something that has been well established several years ago through other observational studies out of Houston. When I was actually a resident back at the University of Pittsburgh, I remember Lou Alicon was doing the analysis looking at transfusion-associated reactions and the adverse effects, and we didn't see that in our patients who got whole blood. And the randomized pilot trial, the POWER trial, which really looked at the feasibility and safety of pre-hospital whole blood, didn't see an increase in terms of serious adverse events with whole blood compared to component therapy. But the other concern is in females of childbearing potential and the risk of alloimmunization and the serious event of hemolytic disease of the fetus and newborn and future pregnancies. And so there have been some data to quote that being around anywhere at the 4 to 5%, but there have been even more recent computational analyses actually showing that that theoretical risk is probably less than that, probably around 0.3%, because there are several events that have to happen in which Dr. Yaser had demonstrated for that serious risk or event to even happen.
And I think that's really important. And so, to sum it up so far, the evidence that we have shows that it's safe, shows that it can save lives, right? We're talking about reduced mortality, which for us, again, as trauma surgeons, bleeding, bleeding, bleeding are the first three things in general that we're concerned about, right? You're the author of this, again, very comprehensive review article. You're an expert on this topic. What do you think is the future of whole blood here in the US, particularly in the civilian setting?
Yeah, I mean, that's a great question. And one of the main points of doing this review article, the evidence is not straightforward at the moment. There is some contradictions with the evidence, but I feel like this review article, we really needed to take a step back and really synthesize the story of whole blood, really, and not just whether whole blood works, but where the evidence is strongest, right? Where uncertainty remains, and really trying to determine who's the right patient, the timing, the dosing, the logistics, and even very importantly, the equitable delivery of whole blood that should shape the next phase of research and adoption. And so I'm very enthusiastic and I can't wait to further understand the benefits of whole blood compared to our traditional conventional component therapy, and really awaiting the results from the TROOP trial and the MADIC trial as well. And so, I do have strong feelings that whole blood is here to stay. We know that it is at least as good as component therapy, but also it's simpler to give as well, if you think about it. And I currently co-direct with my partner, Dr. Mike Valkanis, a pre-hospital whole blood program here in Massachusetts. And I can tell you, talking with our EMS providers who actually are the ones in the field handling all this, they just say it's easier for them. It's less storage devices that they need. They don't need any thawing equipment. They don't have to do all this component tracking. So I think, again, it's as good as component therapy. And I do feel like there are certain populations that we still have not discovered yet where whole blood is probably more beneficial to red cells, plasma, and platelets, recreating that original blend of whole blood.
I love it. Well, thank you so much for joining me, Dr. Torres, today to discuss your article, Whole Blood Transfusion, From Empiricism to Evidence, a Narrative Review. Our listeners can find a link to the article in this episode's description. This episode was produced by Daniel Misisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening and have a great day, y'all.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.